She studied medicine at the University of Otago in New Zealand, and she was a junior doctor at Christchurch Hospital. During that time, she authored the Ophthalmology Emergency Guide for the Christchurch Hospital. She did a registrar training in New Zealand and has completed 2 glaucoma fellowships. The first was in Switzerland at the Bern University Hospital, where her training was in glaucoma and uveitis. There, she also gained experience with non-penetrating glaucoma surgery. For a period, Aparna worked at Sydney Eye Hospital as the emergency senior registrar, and that's where we worked together. After that, she undertook another glaucoma fellowship in Canada at the University of Western Ontario. Aparna is actively involved in research and is committed to ongoing education. And she's currently enrolled in the Masters in Public Health at Sydney University. And she's really committed to giving her patients the best care. So, Aparna, I'd like to welcome you tonight and looking forward to your talk.
Thank you so much for that really kind introduction, Ridia. I really appreciate it. I'm just trying to share my screen at the moment. Can you see that now? Great, awesome. So thank you very much to Glaukos and to Malati and Glenn for the opportunity to share my experiences with the iStent Inject and iStent Inject W. And I'll just be telling you how I implement that into my everyday practice. So my disclosures are that Glaukos has provided me with an honorarium for this short talk. So the goals for this presentation are identifying suitable patients for the iStent Inject W, and also the tools and the consent process that I go through for such patients. Just a whistle-stop tour of MIGS. So it's termed minimally invasive or micro-invasive glaucoma surgery, and it widens our treatment paradigm. There's a large space between now drops and or SLT and incisional surgery. And there are 5 characteristics of MIGS. It's an ab interno approach, minimal trauma to target tissue, at least modest efficacy, favorable safety profile, and a rapid recovery. So what are some of these ab interno approaches? They're transtrabecular and they target the Schlemm's canal. And in short, these are some of the options that are available here and overseas. And this is where the iStent Inject W comes in. Quite topical at the moment is a large review of 3,476 eyes in the Survey of Ophthalmology. I would encourage you to go and have a read if you're interested about this. Just reminding you also of the European Glaucoma Society October 2020 definition of MIGS, and only ab interno non-bleb forming procedures can really be termed MIGS. And of course, the EGS does not endorse any product or procedure involved. So when we talk about MIGS, 2 other features also come to mind, and that's quality of life and whether it's more cost effective than incisional surgery. So when you talk about incisional surgery, bleb forming surgery, they have much higher risks involved, and so therefore quality of life for these micro-incisional procedures is better when compared to incisional glaucoma surgery, remembering that the indications for the incisional surgery are quite different. So you're not really comparing apples with apples per se. Is it really more cost effective than incisional surgery? Well, the jury's out on that, mostly because the stents do cost quite a lot. So important to remember that as well when you're reading some of these papers. Okay, so coming to iStent Inject W, it's a transtrabecular drainage device and allows aqueous to drain directly into Schlemm's canal, knowing that in open-angle glaucoma, the juxtacanalicular TEM is a major site of outflow resistance. And we've known this for a long, long time, not just since 2006, but that's a more recent publication. The heparin-coated titanium microstents, and you can see a picture of what they look like on the right-hand side. So the W is the wider flange, which makes the device much more stable than the trabecular meshwork. And there are 4 outflow channels for aqueous to percolate through into Schlemm's. This just shows you the device itself, and on the left-hand side, it shows us the delivery system, which has also been modernized, and the stylus makes it much easier to engage the tissue and then go ahead with implantation. So this is a picture which nicely shows 2 stents that have been appropriately positioned, showing blood refluxing through the stent lumen itself as well as around the stent lumen. And this is the view that you get through intraoperative gonioscopy when you're doing your iStent placements. So we're now definitely in the era of personalised medicine, personalised surgery. And really, where I've said selecting the best device, it's actually selecting the best operation for each patient, because one size definitely does not fit all anymore. So there are patient factors, and then there are device characteristics as well. So we're talking about efficacy versus risk of complications and further interventions that may be required, and the consent process. And it's really important to remember that with these transtrabecular drainage devices, it's not possible to eliminate use of all glaucoma drops. But the aim is to decrease the dependence on medicines and to lower pressure. So some of the patient factors involved one of the most important features is angle morphology. So open angles, ocular hypertension, and mild to moderate open angle glaucoma is what the iStents are meant for. Important also to think about what your target IOP is. If the the desired reduction in pressure is around 10, well, the stents are not really going to deliver that. Now, it's better to go for incisional surgery. This is good when you desire target pressure of lowering of about 3 to 4. Slow progressors are ideal for this procedure. Patients who have reduced compliance with drops, for example, are also good candidates, and patients who have drop-related side effects may be able to get off some of those drops, and they would also be good candidates. Also good to remember that the vast majority of papers that have been published for the iStent Inject are in patients with combined cataract extraction, but there has been a recent meta-analysis that has been done that I will talk about in a few slides, where standalone stents have been done as well, and with a good reduction in pressure. So coming back to angle morphology again, just get really familiar with the angle features pre-operatively, using a full mirror gonio, or for example, using your SLT Latina lens or a MagnaView gonio lens, which actually I purchased as part of learning to use the stents as well. And I found gonioscopy.org a fantastic resource. I used this at the start of training, and I went back and had a look at it. The picture on the bottom right shows an intraoperative view of the angle. So get used to using your prism with the left hand, turning it, sort of not applying too much indentation on the cornea to change the depth of the angle and of the AC, because you'll be using your right hand to insert the stents. So just sidestepping a little bit here, this is a case of Yvonne, an 83-year-old lady with known ocular hypertension for 5 years on Xalatan. Target pressures have been achieved, vision deteriorating, and so therefore we discussed whether she wanted to proceed with cataract extraction, and she did, and this shows her structure function analysis prior to surgery. She then underwent routine cataract extraction, intraocular lens insertion, eye stent inject, and following surgery we ceased her drops to assess whether the eye stents had been successful, and she's managed for the last 9 months off all glaucoma drops, and she hasn't been followed for more than 9 months with me, but she hasn't progressed in that time while being off the Xalatan. So patient factors are the drop-related side effects, for example, in patients with PAP, such as this lady on the left-hand side of your screen, would be a good candidate, provided she has open angles. And hopefully she can come off her prostaglandin, not that this would be reversible. In patients with brimonidine allergy, for example, that would be another useful indication for eye stents. So some considerations for selecting initial cases: again, open angles, low myopic eyes make for an ideal start because they have quite a lot more room in the anterior chamber, and again pigmented trabecular meshwork, and it makes it much easier to identify the point of insertion of the stylus during surgery. Choose patients with routine cataracts, not dense rocks or white cataracts, or any patients that you feel will not dilate well on the table. So you're avoiding pupil dilation techniques and devices, and really keeping the cataract very simple so that you can go ahead and focus on the eye stent insertion. Sidestepping again, this is Neil, who's a 68-year-old gentleman, ocular hypertension, again on Ganfort for 4 years, and he has had gritty eyes and also difficulty seeing his golf ball when he plays, especially first thing in the morning in the sort of twilight. Pressures at target average CCTs, decided to go ahead with a combined cataract and eye stents in both eyes. And the visual field GPA shows that there's no evidence of progression in spite of coming off Ganfort, and that's over the last 24 months. The little red arrows show when he had the procedure done, and then you can see thereafter there's no evidence of progression. And on the right-hand side, you can see his structure function analysis following surgery. So why particularly eye stent inject W? It's quite a lot more straightforward than other devices that are on the market. There's a single point of insertion for each stent, and so you can really focus and get that point of insertion correct. Important to note that, if both stents are not optimally placed, then you won't get a response to treatment. So in appropriately selected early glaucoma cases, they're definitely effective, and the pivotal study that was published by Samuelson a long time ago, and with further iterations in 2019, showed that it is effective, and that's either in combination with cataract surgery or as a standalone. And this shows the prospective multi-center randomized control trial with 505 patients, and it shows a 31% reduction from baseline at 24 months. But the eye stent inject is also useful as a standalone. So on the left-hand side, apologies for how busy that table is, but it just details how many studies have been published with the eye stent inject in combination with cataract extraction. and on average there's a mean IOP reduction of between 3 and 7. Some outliers suggest that your pressure can drop down by 10. I'm not sure if that's been repeated too many times, but there's also a definite reduction in medication as well. On the right-hand side, that shows standalone iStent inject, and that's a systematic review that's been published recently by our colleagues here in Sydney. So definitely worth a read, and that's in the Journal of Glaucoma earlier this year. It's got a good safety profile, and it's been around for a very long time, since 2012, and it's gone through various iterations to improve the ease of insertion as well. And it just shows, this table down here at the bottom shows, for example, the complications associated with the various MIGS devices. CyPass obviously has been pulled from the market now. And if you're interested, there's a comprehensive review in the Journal of Cataract and Refractive Surgery again earlier this year, which outlines all of this in good detail. So it improves patients' vision, particularly in terms of driving vision, and that's what this questionnaire shows. So how do I go through the informed consent for these patients? I usually have a model of the eye and I go through the process for cataract extraction, if that's what they're having, and then use the iStent model, and that is provided by Glaukos along with the pamphlet as well. And I also refer them to the Glaucoma Australia website, as it's an independent resource, and they can have a look through that as well. And these are some of the post-operative complications that I briefly mention. Elevated, I'll go through this in the next slide as well. So the risks are cataract extraction, IOL insertion plus high FEMA. So the point is to avoid hypotony in the eye straight after, and that lowers the chance of high FEMA occurring. Hypotony does occur, it's usually numerical rather than associated with hypotony maculopathy and large choroidals, and usually settles pretty quickly. If they do get a pressure spike, that can be because of either a significant high FEMA or from a steroid response, and device malpositioning can occur, but this is usually able to be rectified on the table. And I usually also mention that it's made of non-ferromagnetic titanium with heparin coating, so there's no issues at all with MRI scans. So one last case here, this is 65-year-old Jim who was referred with POAG and cataracts, positive family history of glaucoma, pressures borderline at 21, vision down to significant nucleosclerotic cataracts in both eyes. I started him on Combigan because this on the right-hand side shows his early structure function and quite a lot of superior paracentral visual field defects noted there, particularly in his right eye. That was quite concerning. So issues there are the cataract as well as the glaucoma. So thoughts that were going through my mind is, do I go ahead with a cataract and stent, knowing that pressure reduction might not be low enough and then he'll need to go with a trabeculectomy? Or do we do a trabeculectomy at the start and guarantee that the cataracts will get worse, and then we have to do the cataract later, knowing that there's a chance that his bleb will fail because of the cataract operation? So I discussed this with him in detail and decided to go ahead with cataract extraction and stents. Pressures 1 month following the operation off drops was 17, which is definitely not a target in his right eye. So restarted his alpha-GAN. And and he's actually been maintained on that alpha-GAN and has not had any progression, particularly in the right eye, which was of concern. So that brings me to the end of my talk, and I look forward to questions.
Thanks, Aparna. A great talk.
Thank you.
Yeah, I just want to say that participants can send questions through the Q&A. Just type them in, and I'll do my best to get through as many as possible. So we have one question from the audience. I'm interested to know what your medication regime following stent surgery is. Do you continue the glaucoma meds or do you stop them?
Yeah, that's a great question. Usually if they have ocular hypertension and their disc is not at risk of significant progression and they don't have any paracentral visual field defects and their day one post-op pressure is under 25 off their glaucoma drops in the last sort of 24 hours following surgery, then I stop their drops and then I see them the week after and I take it on a case-by-case basis.
So similar to that, Aparna, do you change your post-operative eye drop regime, like the steroids, if they have a cataract with stent, or do you do what you usually do for a cataract?
I do the same. So I use Clorsig, Maxidex, and Ilevro, and that's what I routinely do. Yeah.
So, okay. So thanks for the talk. Do you routinely go near post-op to check the stent position?
Yes.
Yeah. Yes. Yeah. Do you check on day one?
I do check on day one.
Yeah. Same. I always check. Okay. What is the Medicare criteria for iStent? Do you use iStent in ocular hypertensives with the 42705 item number?
I defer to you, really. I'm not sure what is the question asking.
Well, I guess what they're saying is 42705 is the cataract plus iStent, trabecular stent item number. Yes. Would you use that in the ocular hypertensives? Well, I think that if they satisfy the criteria, yeah, you would. Yeah. Okay. Do you have any, like, really your top 3 tips for a new user?
Choose a low myope.
Yeah.
Someone with a pigmented trabecular meshwork, a fair amount of pigmentation. And probably a 2+ nucleoscopic cataract.
Yeah. Okay, that's on your wish list. And what about, like, just frankly speaking, give us some early mistakes that people make and how you should avoid them.
In terms of choosing a patient?
Implantation, like any, like top tips for implantation. Because I guess what you said is that if you don't get it into the right place, it's not going to work.
Yeah.
And that's got nothing to do with the stent. The stent is perfect. But, like getting it into the right place is so important.
Can I share this with you today? I did 2 cases with stents this morning, and I was just thinking about this actually. Yeah. One case was routine. They were all, as I mentioned earlier, fairly straightforward. One case, my paracentesis incision was a little bit too limble and it bled. And that really made the view difficult because it kept bleeding and it kept bleeding. And so I had to wash it off, wash the blood away, had to put Helon on the surface of the eye repeatedly, make sure my left hand was not obstructing and, spreading that blood from the limbal paracentesis incision. That's what I would say. Make sure your surgery is bloodless.
blood is not your friend. Blood is not your friend. So yeah, I agree. Like the view is everything, isn't it? So if you have blood under the lens, it's really very difficult. Actually, a tip for that is you can use a spear and use phenylephrine and put that on the bleeder, and that can vasoconstrict and
Yes.
give you a better view. Okay, so we have another question. In your general practice, what percentage of patients do you believe would be suitable for a combined cataract glaucoma procedure?
I'm sorry, I can't really answer that question because I see very few, just cataracts. I just don't see them. So I'm kind of tending to see a lot of at least the moderate open angle glaucoma who are at least on 2 drops. And then some of them have already been allergic to, say, Alphagan or Cosopt or whatever. They already have moderate glaucoma. And so my aim for those patients is, provided they're stable, I'd like to at least get them off one of these other offending drops and save the ocular surface. And that's, what percentage? I don't know.
I think that would really vary depending on your practice. So do you have a preference of inserting directly into the pigmented meshwork or slightly anterior, overlapping with a non-pigmented meshwork?
I do go slightly anterior. Actually, this was the discussion that we were having the other day. There's that certain fudge factor, I guess. It's implanting a few through that trabecular meshwork into Schlem's, but I found that with the iStent Inject W, I just have to go a couple of microns slightly more anterior so that I can get that heme reflux or the blood reflux through the stent lumen. But then I don't know, that's just me.
The fudge factor. What do you promise patients? Do you promise them anything?
I say that I'm hopeful that their pressure will come down by hopefully at least 2 or 3. It's a bit like adding a drop without giving them an extra bottle. I also say to them that it would be great if I was able to get you off at least one of your glaucoma drops if they're on 2 drops. But there's no guarantees because it really depends on the outflow mechanism, which I can't measure for each patient, and we don't know enough about it yet. That's what I say to them. Yeah.
So there isn't really anything at this stage that you can use clinically to determine who's going to be a really great responder and who's going to have more downstream resistance. So, and I think that's great. Thank you for that, Aparna. Thanks for your talk. That was really, informative. And your tips as well, great tips. So thanks. I think we might, if there are more questions for Aparna, keep sending them through, and we can always, if we have a chance at the end, have a bit more discussion. But we might move on with Smita's talk. So I shall just introduce her. Smita, Associate Professor Smita Agarwal, she's a comprehensive ophthalmologist with a special interest in refractive and complex cataract surgery and anterior segment eye diseases. She completed ophthalmology training and advanced training in cataract surgery at Monash Medical Centre. She also completed a graduate diploma in refractive surgery through Sydney University. She's based in Wollongong. She's previously been the head of ophthalmology at Wollongong and Shellharbour Hospitals. She started the first laser centre in the Illawarra region. And she's an associate professor at the University of Wollongong and senior clinical lecturer at the University of Sydney. She's actively involved in teaching medical students, registrars, and general practitioners in the area. She's interested in education, research, and she's a mentor. And she's committed to the wider community and makes regular overseas visits to underprivileged communities, prior to COVID, that is. So welcome, Smita. I look forward to your talk.
Thank you, Lydia. That was very kind of you. That was beautiful. Slideshow. Can you see now? Can everybody see my screen?
Yes.
Yes, yes.
Is that working now?
Yes.
Thank you. Just want to move these. So good evening, everybody, and I would like to thank Melody, Glenn, and Clockers to invite me to present my views on iStent. And my topic is, it's a very frequent complaint in my practice when the patients come for cataract surgery. Doc, I want to get rid of my glasses and my eyes are very dry with glaucoma drops. I'm going to share a few of my views how I manage my cataract patients who are on glaucoma drops and avoid dry eye disease. So I've been given some honorarium to prepare and present the talk from Glaucos. So how many of you have patients who do not want to wear glasses following cataract surgery and do have glaucoma? So the reality is that today's cataract patients, whatever age, they are more functional and have active lifestyles, and they do quest for precise vision. We are taking utmost care to give best of results, and tear corneal interface is one of the most powerful refractive components of the eye to give us good results amongst all the other factors. 20% people suffer from dry eye disease in Australia, and it is more prevalent in women more than 50 years of age, and also in people who have got autoimmune disease or connective tissue diseases. So I'll share one of my cases. He's a 77-year-old gentleman, and he's got glaucoma. He's been using a Xalatin eye drop, one drop at nighttime in his both eyes since 2012. His pressures have been under control. Initial intraocular pressures were in 30s. So I started him on Xalatin initially, and the pressures were around in mid-teens. I changed them to Travatan in 2018 as pressure started to creep up and there were some visual field changes noted. His pressures got better, but they were still fluctuating, and patient was getting affected with dry-eyed symptoms. Compliance was an issue. Adding another drop would have created a scene. So luckily in 2020, he developed cataracts and his vision deteriorated. Patient wanted cataract surgery with an EDOF lens and asked if at the same sitting something can be done for glaucoma. So what I did was I organized cataract surgery with Vivity EDOF lens, and I discussed with him iStent inject. I gave him the brochures to read. I discussed few things about it, what issues can happen. He happily decided to go ahead with cataract surgery with iStent. His visual acuities postoperatively were 6 by 7.5 in his right eye and 6.6 in his left eye unaided. Near and intermediate visual acuities binocularly were N5. His intraocular pressures were in mid-teens, which is what I was getting with prostaglandin analogs initially, but now cornea is much better. Vision is not compromised due to dry eyes, and patient is enjoying his vision with his EDOF lens. I am happy, patient is happy. So this is just one of my many patients, happy patients. So glaucoma is one of the most common diseases, in the world, and globally its prevalence is 2.2%. 89% of patients use glaucoma drops. Most common side effect is obviously ocular surface disease. 80% patients have got meibomian gland disease. We all know that chronic use of topical glaucoma medications can cause dry eyes, and it has been linked to limbal stem cell deficiency. We try using preservative-free glaucoma medications, lubricating drops, anti-inflammatory eye drops, sometimes punctal plugs to reduce the symptoms. I would say do not forget ocular surface when you are prescribing topical drops, because non-compliance is usually associated with eye drops, and it has been seen in 23 to 90% patients due to side effects, forgetfulness because of dementia or aging, inability to use the drops because they've got weak fingers due to rheumatoid arthritis, old age, and they are not able to press the bottle. They could be having allergy to drops, superficial punctate keratitis. They can be unstable tear film or corneal ulcers. As glaucoma progresses, we try to add more drops, and what we see is non-compliance because of the side effects in preservatives and too many eye drops causing further superficial punctate keratopathy. Patients become symptomatic. When glaucoma patients present to our rooms, they are asymptomatic, and we start them on these drops, and all what they get is red, sore eyes. I've had patients complain to me, "Doctor, I came to you, I had no problems, and now I'm getting red, sore eyes." So, and patients have got few more other appointments to deal with besides using drops 8 to 10 times per day, 8 to 10 drops per day. Patients are getting frustrated as there's no quality of life due to constant nagging pain and blurred vision. Obviously, we can reduce drop burden by a few other things like SLT, minimally invasive glaucoma surgery, and or trabeculectomy and other surgical interventions. We can also treat dry eye disease. So most of the times what we do is we examine dry eyes on the slit lamp with their complaints when they're having with fluorescein staining. These are most commonly used tests. Other specialized tests, of course, are there: mammography, LipiView, tear osmolarity. But the reality is not many people use them on day-to-day clinics. We can do tear supplementation with lubricants, tear stimulation with cyclosporine. We can do punctal occlusion, which has also been seen to reduce intraocular pressure due to better retention and absorption of prostaglandins. So ocular surface disease in glaucoma, what we find is that there's increased levels of interleukin-6, TNF-alpha, VEGF in the tear samples of glaucoma patients who have been on chronic topical prostaglandins. There's lower expression of interleukin-1 beta who are on preservative-free prostaglandins. A study was conducted in 2019, and they found 46.7% patients had there were elevated levels of MMP9 in 46.7% of patients who were on preservative-containing glaucoma medications versus 16.7% of patients who were on preservative-free or untreated patients. So it's pretty high level of inflammatory markers in patients who are on glaucoma drops. These days, there's an increased uptake of premium intraocular lenses because we have got better intraocular lenses, and they are younger patients who are doing much more, have got much more functional lifestyle. Most of us are using smartphones and do want at least functional vision. And we all know that the outcome of premium IOLs depends on multiple factors. We all are good surgeons. We all follow our rules, but still, patients do not get good results if they don't have good corneal surface. I tell all my patients prior to cataract surgery to do lid hygiene and use lubricating drops who have got meibomian gland disease, but compliance is an issue. Patients think, okay, I'll get the surgery done, everything will be done. And when they do not achieve good results post-surgery due to dry eyes and poor tear film, and the surgeon and the implant is unfairly blamed. It's been seen that 50 to 60% of patients have got meibomian gland disease, which gets worse post-surgery with post-operative steroids and antibiotics. It's almost impossible to convince these patients who have had premium lens inserted that their poor quality vision and pain in the eye is not due to the implant or due to the surgery, but it is due to the ocular surface. It's very, very important because you guys will be starting to diagnose all these issues and document in their records and talk to patients that, look, there can be some issues post-operatively if you do not prime your corneal surface preoperatively for any kind of lens, I would say, but more so with any premium lens. How you can avoid is by what I do in these patients is when patients are wanting cataract surgery and are on glaucoma drops, I obviously treat them judicially with lots of lubricating eye drops and lid hygiene. But whosoever fits the Ransco criteria, which is basically patients who have got glaucoma and are not adequately responding to topical drops or intolerant to drops, I offer them eye stent. So these are the different types of MIGS available. I use only eye stent because it's very easy to use. I like my life simple. I'm a cataract refractive surgeon. I'm not a glaucoma surgeon. I like to use something which is simple, easy to do, and gives good results. So Aparna has already gone through in detail with the new eye stent inject, which is basically have got a bigger flange, so it's much more predictable and it gives consistent implantation. And the insertion system is also, the insertion sleeve is also enhanced, and we can visualize both the stents at the same time. These are other standalone procedures for which I refer my patients to glaucoma surgeons. So why do I choose eye stent? Because I'm not a glaucoma surgeon. I'm a cataract surgeon. My aim is to restore and give good vision. And eye stent devices are easy to use. They don't need much skill to learn. There are not many post-op issues. My indications are in any patient who's undergoing cataract surgery, who has glaucoma and has got dry eye disease or has ocular surface disease, wanting premium lens. I do eye stents only in patients who have got mild glaucoma. Usually they are using 1 or 2 eye drops and their pressures are controlled. Or patients who are elderly, who have difficulty in administering drops like Parkinson's, tremors, rheumatoid arthritis, or dementia. So I would play this video and I will tell you that it's very, very important to visualize, as Dr. Lim and Dr. Reniga also explained, that visualization is the key. Once I finish the cataract surgery, I tell the patient, look, I finished your cataract surgery, now I'm gonna do the eye stent. So I turn the microscope towards me and then I turn the patient's head away from me. Prior to that, my instructions are to the nurses that please check all the expiry dates and everything. Do not waste any time. When I asked for eye stent, I wanted ASAP because I don't want the blood from the incision side to trickle under the gonio prism and block my view. And I don't want patient to be lying in that uncomfortable position for too long, as they're elderly people and they could have neck issues. So once I turn their head, I put lots of viscoelastic and I flush away all the blood so that no blood seeps under the gonio prism. Use my left hand, visualize the angle. Once I see the trabecular meshwork, I ask for the eye stent from my nurse. So I make sure that there's no blood going underneath the prism, and I go with my right hand, visualize the trabecular meshwork, and I insert both the eye stents. I insert about 2-3 clock hours from each other. And if there is blood reflex, that means I'm at the right place. And I put pressure for a few seconds to reduce the chances of hyphema post-operatively. I also keep the pressures a little bit on the higher side to avoid any hyphema. So this was a slide which was shown by Dr. Renega as well, and this was a meta trial which did show that there was better reduction of intraocular pressures when cataract surgery was combined with eye stent. Most patients achieved better visual outcomes post-cataract surgery who had eye stent injected as well. Obviously, ocular surface was much, much better. Ocular surface disease index, tear film breakup time, staining of the conjunctiva and cornea, conjunctival hyperemia, everything was much, much better and reduced as they were not using glaucoma drops. There was 72% reduction in the percent of patients with severe OSD symptoms when they had combined cataract and eye stent injections. This was one of the papers in JCRS recently where they found complications with the combined surgery with cataract surgery and eye stents, and they found some malpositions. I think it is probably when the stent is not injected at the right place. 2% people needed reoperation due to stent obstruction, which happens most often when there is a persistent hyphema. 0.5% needed implantation of another device. So these are my results. On 65 eyes who underwent cataract surgery with eye stent, I found 7% decrease in intraocular pressures postoperatively. So preoperatively on glaucoma drops, their pressures were about 15.4. Postoperatively on no anti-glaucoma drops with eye stent, their pressures had come down to 14.3 millimeters of mercury. So what I tell my patients is that each 1 millimeter decrease in intraocular pressure reduces the risk of progression by 8%. But what more relevant is that each millimeter increases your risk by 13%. So anything which is giving you better reduction and avoid ocular side effects, I think they are happy to give it a go to eye stent. So there was significant improvement in visual acuity in patients who underwent cataract surgery with eye stent, and there was no blurred vision due to dry eye disease. 90% patients did not need anti-glaucoma drops, but mind you, I select my patients very carefully. I use eye stent only in patients who have got mild glaucoma, which are controlled on 1 or 2 eye drops. 83% patients did not need any lubricating eye drops post-operatively. So to conclude, I would say that I like to use eye stent inject in patients who have got mild glaucoma, who are controlled on 1 or 2 eye drops, who are having cataract surgery and have either dry eye symptoms or compliance issues causing IOP fluctuations and or progression in glaucoma. My threshold is low for patients who are wanting premium intraocular lenses. Anything advanced, I refer to my glaucoma colleagues. So I would say my patients are happy because they are getting eye stent inject. I'm happy because patients are not coming every 6 weeks after cataract surgery complaining and blaming me that their vision is not good because of my bad surgery or bad lens or bad choice of lens, wanting explantation, whereas it is because of dry eye symptoms. Patients are happy, I'm happy, cornea is looking good. So I like to use eye stent in patients where I can. These are the usual excuses for non-compliance to glaucoma drops pre-lockdown when they would go traveling, forgot to use the drops. So that comes to the end of my talk, I think. Thank you. Any questions? I'm happy to take.
Thanks, Smita. Thanks for that. It's really great to get the opinion from the perspective of a refractive surgeon. You know, I think it's you have to manage these expectations. I mean, refractive patients have notoriously high expectations. So congratulations to you. I mean, do you just the same question that Aparna had? Do you, in these eye stent cataract patients, do anything different post-operatively with the post-operative drops? Do you restart?
I don't do anything different. I just continue with the same regime as I do for my routine cataract patients. With the glaucoma drops, I don't I asked them if the disease is mild, I'll probably ask them to stop using the drops after 1 or 2 days and get them back in a week's time to check their pressures. If the pressures are well under control, I don't ask them to continue. But if the pressures are not controlled, I'll say continue using for a month and let's see how it goes, because you're using steroids. You could get steroid response and that can cause pressure to go up. But later on, if it is looking good, I'll stop the drops.
Yeah, great. Actually, are there any questions from the audience? Please send some questions through. This is one for both you and Aparna. Are you doing many standalone cases? Or Smita, in your case, are you doing all combined cataract eye stent cases?
Yeah, I do mainly combined cataract and eye stents. I have done few standalone eye stents, but not many.
Yeah. And Aparna? Mute. You're on mute.
Sorry. I haven't done standalone cases. I guess the patients that I see are already on 2 drops, and there's some evidence of progression. Although the most recent meta-analysis paper has got really good results. So I will be choosing wisely.
Yeah. Look, I think that we fought long and hard to get that standalone item number, but as we predicted, the numbers that we're implanting them in are not huge. It is a very select. We're lucky to have the standalone item number and to have the option of giving it to patients who are phakic or have had previous cataract surgery. So even so, the numbers are not big. And as you mentioned, the Sydney, the meta-analysis is a good paper. Okay, so we know how non-compliant patients are with eye drops. When you see a patient with obvious signs of progression and poor ocular surface disease as a result of prolonged drop use, do you actively discuss the potential for a standalone stent implant? And if so, how do you convince a patient to head to surgery? Or are they keen to proceed to surgery with the hope that they can reduce the medication use? So,
is that for me?
Aparna, do you want to tackle that one? Yeah. Mm-hmm.
Yeah, Aparna.
So really it comes down to those 2 questions that I mentioned at the start. It is about rate of progression. So how fast are they progressing? And what is their field of vision like now? Is there any paracentral loss of vision? How much retinal nerve fiber layer have they lost? How quickly have they lost it? That, along with my target pressure and the desired drop in pressure that's required, allows me to match up what kind of procedure I will tend to offer. So with stents in my hands, I tend not to promise anything more than 3 or 4. If they need anything more than a drop of 3 or 4, then they're not good standalone or combined cataract and stent cases. If they need anything more than that, you're looking at other more advanced, more incisional approaches to deliver that.
Yeah. Smita, do you have anything to add to that?
Well, I'm looking for cataract somewhere in that eye so that I can do combined cataract and eye stent. I would do eye stent if there's somebody who's rapidly progressing and not under control on 2-3 eye drops and getting lots of side effects. I'll probably send them to one of my glaucoma colleagues for something more than eye stent, because I don't think eye stent would work if there is somebody who's getting pressure is not getting controlled. This progressing advanced nerve fiber layer changes with 2 or 3 drops. And I'll let them decide what they would like to do if there is no cataract.
Okay, the next question. Do you give all iStent patients Diamox post-op? Diamox. Would you use in a patient on anticoagulants or make any adjustments?
I routinely give one Diamox to patients who are getting, because I usually intentionally keep their pressure high post-operatively. So I do give them one tablet of Diamox about a couple of hours. And I don't have any different regime with anticoagulants. I don't stop anything.
Yeah. Yeah. I don't give Diamox, but I ensure that I've done a really good in IA. No, you don't want to leave any viscoelastic in the eye. So I don't give routine Diamox, and I don't treat the anticoagulants any differently. Okay. For your referrers, are they typically aware of MIGS options? And letting the patients know of options before they come to you? It's quite interesting. I liked, Aparna, you know, I must say, I have definitely gone away from talking about MIGS. You know, I much prefer to talk about what the devices actually do. I'd rather talk about trabecular stents or a subconjunctival bleb forming procedure using a device. I think that although when MIGS, the term came out, it was a good term at the time, I think people are moving a bit more away from using the term. But I think because we, as you said, Aparna, the in your definition, they weren't including the bleb forming procedures, and originally they did. And I think many people argued that they weren't that minimally invasive because of the mitomycin.
That's right. And the needling rate. I mean, with the Zen, it sort of started at 20%, and then some papers were coming out saying it was up to sort of 40-50%, which is a lot of needling. It's definitely not minimally invasive, that's
right. So, and I guess with also the suprachoroidal stents not really being in the picture right now, we've really just got the trabecular drainage devices. So, I don't. Do you think that patients really know much about it before they come to see you?
So, some know about it because they've watched it on TV. Some know because they are members of Glaucoma Australia, and so they get sent out quarterly newsletters. But there are very few patients who will say, oh yeah, my neighbour had it or my friend had it.
Yeah, I think that if they know about it, it's almost, you have to start underselling it because they would come with expectations. Yeah. So do you, how do you find that, Smita? You know, you've got these refractive patients who have these premium precise lens, precise vision expectations, and then on top of that, you're putting in a stent. I mean, what if they were on one drop, and following the surgery, they still have to be on one drop? How do you manage that situation?
Yeah, it's a tricky one. I usually talk to them in advance that most likely, yes, it'll be good, but there's a possibility it may not happen. Then I probably prime their cornea for some time and then give them preservative-free eye drops, give them lots of lubricants. But yes, it's a tricky one, Aridia. It sometimes gets really difficult to manage because if the corneal surface is not good, none of those premium lens patients are happy.
Yeah, I'm glad I don't have your job in some ways. I think we're dealing with much less expectation. Would you prefer to implant the eye stent before or after the lens removal? Okay, so I think there are two camps. There are people who like to insert before. There are people who like to insert after. I'm a before the surgery implanter. And but I would say to that, don't do this in your early cases. So definitely do it afterwards when you're starting out. What do you think?
I usually do it after the cataract surgery because that's my main surgery.
Yeah, I think I do the stent before because I'm a glaucoma specialist. And for me, putting the stent in is far more important than the cataract surgery. What you'll find, though, is that if you implant, I just use Viscoat and implant the stents. So if you implant before the cataract, you'll need much less viscoelastic because the lens is in place and you can just fill with Viscoat and implant it and then do your cataract surgery standard. If you do it after the cataract surgery, you'll need much more viscoelastic because of the lens is gone. Aparna, do you have anything to add to that?
I agree. I've done it both ways, a series of both ways. I prefer doing it at the end because there's quite a lot more room. And yeah, I guess it's just personal preference.
Yeah. I think that putting it in before cataract surgery is really good practice for putting it into phakic standalone cases. So that's, but on the whole, I think all early users should put it in afterwards. Yeah. Okay, so for an early user of iStent, do you say to patients, what do you say to patients in terms of what they should expect from the surgery? Smita?
Well, I talk to them. My main emphasis is basically on the cataract surgery, and with the eye stent, I'll say, look, I'm doing a cataract surgery. It'll take me a couple of minutes extra while I'm doing it. I'll put the stent in the drainage angle, and what it does, it helps drain the fluid, keeps the pressures under control. You don't have to use glaucoma drops later on. Remember how your eyes used to be so dry, blurred vision, having symptoms, burning sensation, all those things will go. And hopefully you will not need to use glaucoma drops in future. You may need to use some lubricating drops for a couple of months after the surgery because of the drops that you're using and to prime your cornea back to your usual corneal self. And after that, it should be good. But sometimes it can be need to use some glaucoma drops if need be. Then look, your vision is more important rather than dry eye symptoms. I just counsel them that way.
You could tell them you showed your nice results. Now, what you showed in those results was that you went from medicated pressure to unmedicated pressure. The postoperative unmedicated pressure was a millimeter lower than and so you can say that, most people, the pressure decreases slightly and on fewer medications. That's most people, but not everybody.
Yeah, it's better I like to undersell because raising the expectations sometimes gets really hard to manage patients post-operatively, just in case if that one person comes with higher pressures.
Yeah, no, agreed. So
I also wanted to add a couple of things. One is that you tell patients that it will take longer. They have this sort of mental clock where they think, their operation's going to be done in 15 minutes. And so anything longer than 15 minutes is too long, or they've had a complication. So it's just good to tell them it will take longer. It's actually more difficult than doing the cataract because, you've got to set it up and the magnification and everything. And I'm not sure I would do the initial cases as a second eye. As in, I would choose their first eye for the stent and then do the second eye like that, right? So that they don't have that comparison of a time frame between the two eyes, if you know what I mean. The second eye shouldn't be with a cataract and a stent, but that's just a suggestion.
Yeah, no, I think we've come to the end of the questions. It's been really, it's a great learning night. And so I'd like to thank you, Aparna and Smita, and Melody, if you're still there, thanks to Glaucos for putting this education night on. Everyone says thank you. Yes, thank you to Glaucos, and until we see each other again face to face, it's been really nice seeing you this way.
Thank you.
Tomas.
Bye, Melody.
Bye. Thank you.
Thank you very much. Bye-bye.
Bye-bye.